Pompe disease, also known as glycogen storage disease type 2 or acid maltase deficiency, is an autosomal recessive disorder. Pompe disease is caused by a mutation in the GAA gene, which affects the production of an enzyme named lysosomal acid 1,4-glucosidase, or alpha-glucosidase for short. Glucose is used by most cells in the body for energy and is stored as glycogen in cells. Small amounts of glycogen are stored in the lysosomes, and acid alpha-glucosidase breaks down the glycogen to release glucose. In Pompe disease, not enough functional acid alpha-glucosidase is produced, and as a result of this, lysosomes can't break down enough glycogen, and leads to a buildup of glycogen within the cytoplasm of the lysosomes. In Pompe disease, the buildup of glycogen in the lysosomes causes the lysosomes to expand until they take up so much space in the cell that the cell is damaged. Glycogen then begins to leak out of the lysosomes and causes more damage to the surrounding cells. Usually, the largest amount of glycogen is stored in the cytoplasm of liver cells and 3 types of muscle cells. But in Pompe disease, it is stored in the lysosomes of these cells instead. Skeletal muscles include the voluntary muscles of the cell, such as the arm muscles, as well as the diaphragm, which helps us breathe. Cardiac muscles make up the heart, and smooth muscles make up the wall of the blood vessels and other organs. So the mutated GAA gene results in acid alpha-glucosidase deficiency, which leads to ineffective glycogen breakdown and a buildup of glycogen in the lysosomes, which ultimately results in cellular damage. Because Pompe disease manifests as a clinical spectrum, symptoms, rate of disease progression, and extent of organ involvement varies with respect to age of onset. Because of the variation in age of onset and degree of organ failure, the disease has been labelled by the subtypes of infantile and late onset, juvenile or adult onset. The infantile form appears in the first few months after birth, and the effects of glycogen accumulation are very pronounced in the heart. Lysosomal glycogen accumulation results in a significant amount of cardiac hypertrophy, and because of an enlarged heart failure may occur. The weakening of the muscles, including the diaphragm, cause respiratory weakness and sometimes failure. Without treatment, the respiratory and heart complications would normally lead to death by the age of 12 months. The infantile form is characterized by a total lack of the alpha-glucosidase enzyme, or by near total inactivity of the enzyme. Because of the heavy glycogen content in the muscle, liver, and heart cells, these cells are most quickly affected. In infants, the rapid onset of the disease in heart muscles results in those being significantly damaged very quickly. The diaphragm muscles being damaged leads to respiratory failure, and liver cells damaged lead to liver failure. The delayed onset form can present at any age. Delayed onset patients produce a minimal amount of enzyme. The progression and severity of the disease are attributable to the amount of enzyme produced and to the age of onset of symptoms. Someone with less enzyme would present at a younger age as a juvenile, but someone with better enzymes, more functional enzymes, would present as an adult. The glycogen buildup is not as rapid as the infantile form, but the disease is still progressive and can greatly decrease the lifespan of the afflicted person. In the delayed onset form, deterioration of muscle is mostly confined to the skeletal muscle, the diaphragm, the limbs, and the trunk. respiratory complications the main cause of death for delayed onset patients. And these patients that present symptoms earlier in life as juveniles are usually more severely affected and rarely live past the second or third decade of life. Patients that experience onset later in life as adults generally progress at a slower pace. Because of the slow onset and variable symptoms, the delayed onset patients can be difficult to diagnose, and the diagnosis can take many years. The diagnosis involves a blood test being taken and the enzymes in the blood being studied and counted. There are also other tests, such as sleep studies, breathing tests to measure lung capacity, and electromyography, which is a test that measures how well muscles work. Some doctors may also take a complete patient and family history to see if the disease runs in the family. And some may choose to do MRIs and further heart studies, including X-rays, electrocardiograms, and echocardiograms. The prognosis in the infantile form is much better with treatment, and infants can still live to be a couple of decades old. As an adult, there can be early death depending on the severity, and some may develop chronic disability due to their muscle deterioration. Although there is currently no cure for Pompe disease, different treatment options can help to ease its symptoms. Enzyme replacement therapy is used to increase the levels of alpha-glucosidase in the body and reduce the accumulation of glycogen inside the cells. Doctors recommend that the treatment be started early before significant muscle damage occurs. Australian hospitals offer a test for Pompe disease as part of their standard newborn screening. The early diagnosis allows treatment to begin soon after birth, and babies treated early are less likely to require a ventilator to help them breathe, which improves their chances of survival. Many patients who receive enzyme replacement therapy produce antibodies against the injected enzyme and may develop an immune response to the treatment, which affects its effectiveness. Medications can, however, be used to address the response to enzyme replacement therapy. Most patients will also require supportive therapies to address the symptoms of Pompe disease. Some patients may require a ventilator during respiratory infections or at night. Physical and occupational therapy can improve patients' muscle strength and help them learn to use canes or walkers if necessary. Speech therapy can be helpful if a patient's mouth or tongue muscles have been affected. The weakness in these muscles can also make it difficult to swallow, which leads to problems with malnutrition. Infants with Pompe disease may need to use a feeding tube, but patients with late onset Pompe typically don't need so much assistance, but they may also benefit from a soft diet. Currently, researchers at Duke Health in South Carolina are working on a gene therapy approach that could allow Pompe disease patients to produce their own functional GAA gene, a step which would help avoid immune reactions to enzyme replacement therapy and aid patients for whom enzyme replacement therapy is not effective. Gene therapy aims to restore the body's ability to produce functional acid alpha-glucosidase enzyme on its own by providing cells with a functioning copy of the GAA gene. The functional copy of the gene is delivered to the body using a modified virus as a vector. The vector transports the gene inside cells and integrates it into the genome of the patient, providing cells with a new healthy copy of the GAA gene that can be used to produce the functional enzyme. These vectors can be targeted to specific tissues in the body, including effective organs such as the diaphragm, for example, to improve breathing capacity. Here are some of my references. Thank you for listening.